Go ahead and get started in the interest of your time. It's a good looking group of people. Thank you all for joining us for a little bit this afternoon. Gonna run through our monthly stars meeting. I see potentially a couple new faces. So if you're new here, thank you very much for joining us here today. We appreciate
Okay,
you.
I'm in.
Um, Gonna hop in. Let's see. Perfect. He got muted. All right. We're gonna do a couple call reviews here today, and then we'll get down to a little bit more of the nuts and bolts and the metrics going on. So, gonna start with a couple calls from last month. First one is 1190. You can see this kiddo's history. Got a bit of a neuro history with seizures, cerebral palsy, and then some heart challenges. One of the common trends for this month's call reviews, everybody was kind enough to call in the middle of the day, so no middle of the night wake ups. But you can see this was an afternoon call for seizures. Um, and then you can see just the vital signs for the call and transport down there. So we got a first set of vital signs and then a bunch of heart rates from there. So this was a school call. So just to touch back to some of the education and training we do, just, schools being that automatic place, we know the primary caregiver is not going to be present with the kiddo. This kiddo was in the school nurse's office, and the school nurse is very familiar with him. She noted him to be having some cluster seizures, and was concerned to the point and followed the seizure action plan that she ended up administering his emergency dose of rectal diastat, and then called 911. So EMS did converse with mom on the phone. As far as the chief complaint, there was approximately about 10 seizures lasting about a minute each over a 30-minute period. So I was just going to touch on that. So we, in some of our epilepsy training, talk about cluster seizures, but that's just those recurrent seizures. They're usually shorter than our definitions of status, but they just keep having recurrent seizures time after time. I grabbed this kind of definition and description from the International League Against Epilepsy. It is an amazing website. If you ever need some resources for your seizure patients, either to train your healthcare providers, or there's a bunch of resources for family on there. So just a good resource to know about. Um, I did think it was interesting that as you have cluster seizures, the muscular actions tend to get more prominent throughout, is apparently a standard hallmark of them. So just thought I'd take a take a moment on this call to learn a little bit more myself and share that with you guys. So some of our patients, of course, are a little more prone to cluster seizures than others. For this kiddo, he did not have any more seizures after receiving the diastat from the school nurse, was just monitored by EMS for transport. They did a little bit of a gut check while he was here in the ED. He had been in recently for seizures and gotten some new medications. So they kind of did the evaluation of whether, the medicines are working or not working, and decided it was still in a decent enough window that they just needed to continue his standard regimen and keep him going on those. So that was just kind of his ED outcome there. Family felt comfortable enough and they ended up taking him home. So just a little bit of a review on that. Direct to tertiary, we're always appreciative. They did bypass multiple facilities to bring him directly to us, and could immediately get the neurology fellow involved and make their decision there. Just a little bit of room for improvement from my perspective. That's not very many sets of vital signs for a patient who's sitting there with altered mental status in front of you and also received a dose of benzodiazepines prior to your arrival. So, if nothing else, probably a pulse ox and a respiratory rate would be worthwhile monitoring throughout transport. So, those were just some things that kind of stood out to me over 46 minutes. You probably shouldn't only have a single full set of vital signs. So, as we can all learn from each other, though, right? Going to move on to, or I'm sorry, I guess for any questions about that one before I move on to the next call. See a chat. A real person or a note taker? Oh, it's the note takers. All right, we're good. All right, moving on to star 702. So this is a well-known patient to stars and her EMS agency. She has trisomy 18. For those of you who are unfamiliar or haven't had a patient with this yet, Kind of similar to trisomy 21 in that it impacts a lot of body systems. It does typically tend to be much more severe than trisomy 21, and these kiddos can really struggle with a lot of the multi-system impacts that they have from that genetic alteration. Also, you can see a pretty substantial CHD history and a history of seizures and pneumonia and infections as well. So once again, an afternoon call hit back in September, this time for respiratory distress and also some potential seizures going on. Do have more extensive vital sign sets for this call, just about every 20 minutes there. And you can see as far as kind of remained a little bit tachycardic throughout. And just SATs were sitting right there a little bit at our PALS borderline in title, just a tiny bit low, but they did trend in title, which I'm always appreciative of. So I won't read all of this to you, but one of the things that just kind of really stood out to me as I was reviewing this cruise trip sheet, they documented mother's impression of the patient, which is always a pretty useful thing to do for a lot of our special needs kiddos. And something that just stood out to me, just a reminder that these parents are practically healthcare providers, is this mom is straight up giving you the pediatric assessment triangle. You know, she's saying like, yeah, this she's working way harder to breathe than she normally does. She's using accessory muscles, and so and she was desatting at home prior, and mom had already tried, upping her oxygen prior to calling 911. So just, a lot of our family members are acting like other healthcare providers out here. They're kind of following the same sets of rules that we all work on. And so it kind of stood out to me significantly there on that front. So they did end up transporting this kiddo in, doing just a lot of oxygen support. Didn't really need to do any suctioning, but did bring them directly down to us. So usually when I kind of teach on these or have given you guys case studies on these before, it's high likelihood it's usually some sort of pneumonia or respiratory infection. Occasionally we talk about the CHF from the heart failure kiddos. But this one really stood out to me as we got the ED diagnosis and workup straight out of left field. So this kiddo was diagnosed with what I might commonly call pseudo TET spells. So for those of us who don't work on children's transport teams and trying to scramble back and remember TET spells, which is the kids who get into trouble because they can't get good blood flow from the right side of their heart to their lungs to oxygenate the blood. It turns out that this kid's heart pathophys very closely mimics tetralogy of flow. And as she was getting sick, she was actually kind of mimicking that pathophysiology, which they figured out over a couple of weeks in the ICU. Ultimately, it was kind of linked actually to eating events, which were causing her to have some decompensation issues. And so ultimately, she ended up going home on TPN through a central line for her nutritional feeding. So just every time I think I've learned a lot of it for these kids, I am surprised and shocked by something new. So I just thought I would share this call a little bit of kind of that reminder of just how complex these kids, can be when all their history starts working together. I won't speak for all the other pre-hospital people on this call, but when I worked on the rig, you were allowed one problem, right? Like you weren't allowed to tell me like, oh, you're sick to your stomach and you got chest pain and your head hurts. Like, no, like we're gonna pick a problem. And I'm just reminded as time goes on and I write more and more of these stars forms that, once you have complex medical problems, they actually can really very quickly start to tie in all together. And so just, really paying attention to just doing really good basics of vital signs and status and checking and kind of asking that good recent history of what's been going on is really the only way that even in the ED they can start to really put that stuff together. And so it just comes back to being a really good clinician. So I thought this is one of the hardest of the hard cases, but just to kind of emphasize how much to do the basics of checking good vital signs, supporting oxygenation, fluids if it had been needed, but really having your mind open on the list of differentials of what could be going on with the patient. Um, and also, I know some of your agencies have already seen kiddos who go home with central lines, but I just wanted to give for everyone else who hasn't seen it, These are the standard instructions we're writing in for the kids who are going home with some variety of central lines there. And just, that reminder of like that's really cool that we can send a kid home to live with their family and their community with a device that helps them safely live there. But it does give us the added challenge of now we're not only troubleshooting a patient, but devices that come with them. And you can run into some challenges and issues with those PICC lines. That's, of course, an excellent source of infection. So looking closely at the site to make sure it doesn't appear to be infected, checking your patient for other signs of sepsis. And then also there are some issues with them becoming dislodged and causing bleeding, in which case you're going to do normal bleeding control. Or if they get dislodged too far inwards, you run a risk of some irritation to the heart. So EKG monitoring is definitely recommended for that. So direct to tertiary, we are appreciative of that. And then waveform capnography, as I mentioned, and really didn't have a ton of room for improvement to give them here. Certainly would never fault anybody for not being able to pull a TET spell on a non-TET kid out of the field. So just kind of an interesting case for us all to learn from, though. Any questions about that one?
Hey, Nick, I got a question. I
Yeah.
don't know if you'll know the answer to this, but did that did they try, or and if they did that kiddo respond to like legs to chest? Like, where you sometimes with those tech kids when they're in the middle of those tech spells, pushing legs to chest can help them kind of come out of that.
Yeah, so they didn't really pick up on the pathophys of what was going on with this till they got to the ICU. And like all good ICU providers, they just went to the cool tools. And I
Yeah,
think skipped the BLS component.
sure.
They did note in the charting that, as far as did react very well to standard TET pharmacology treatment, like they were giving just a little bit of sedatives and some oxygen boost, and we're getting good returns from that. So she did end up acting like a normal TED kid, but there was no documentation of trying physical maneuvers.
Yeah, I know that on some, when we have the tech kids on our side, if there's some documentation that they do respond to that, that's something that I'll put in there because it is a measure that, our pre-hospital folks can, you know, try. I mean, not that they spend eternity on it, but that's scary.
Yeah, no,
For
for
them.
sure. And I think it's a good call out too, just because you never know when we'll have a BLS rig running on a kid as well, and they don't always have access to, morphine or fentanyl. So it's
Yeah.
good to remember the basics too. So
Thank you.
Star 1514 was a transport as well. I believe we actually talked about this kid a little bit last month too. But he is a trach patient out of North County here. And he called in the afternoon as well, very kind of all of our patients. And you can see they call for respiratory failure and distress there in the home. And they did end up finding him. I thought actually some great documentation of how they found him as far as, seated on the edge of the couch and he's kind of altered mental status that was getting worse. He was lethargic. And then they just good documentation of that initial find for sure. Had poor tone to his extremities and moderate respiratory distress, and then they noted that he just continued to decompensate throughout the encounter. The vital signs are a little bit all over the place. I'm sure this is because they're being auto-fed in from the monitor, and patients in distress and in severe situations, sometimes that doesn't read right. I will say the tachycardia may remain consistent. I think it's just the blood pressure that probably wasn't the most accurate throughout the call, or at least not until towards the end. And then you can see SpO2 definitely all over the place, albeit they were arguing, as far as saying like he had pretty poor capture there at the beginning. And then they were able to get him on some end tidal as well. So and I think if we can note the end title, I think for a lot of us, we're looking at that and we're like, what in the world's going on there? Is that thing even capturing? But I think when we get to the end of the case, this will make just a tiny bit more sense as well. Um, so he was assessed on scene. They kept up the O2 that the family had started. They moved him to the rig, and really were getting minimal improvements to SpO2. They did attempt to bag him a couple times, and then ended up suctioning him a few more times. They got the oxygenation kind of get up to those 70s, and that's where they kept him. So there you can see all of their treatments are documented here as they brought him to us, and what they were able to suction out of him. So they said that they got about 5 cc's out of the trach. As far as our ED, this is their initial course of, this kid showed up in acute hypoxic respiratory failure with low SATs. They thought they were noticing some pretty significant air leaks around the trach, and they actually struggled with that. They ended up doing 2 trach changes in the ED, trying to get it appropriately situated, and making sure they didn't have a leak. And even then, they weren't sure until they got Pulm involved into the room, and they were pretty sure that the air leak had been mitigated at that point. Um, of course, he was moved to the PICU, and then down here in the bottom right, you can see a bit of his longer course where he had pneumonia and respiratory infections, and then ended up being kind of a difficult vent patient for a while. So part of his challenge, and it wasn't well appreciated when he initially arrived the ED, is that this is a 13-year-old trach patient. And he has a mind of his own and likes to make himself comfortable. And he doesn't actually like the way it feels whenever his trach is resting all the way down in. And he has a habit of slightly dislodging it himself to reposition it just so it's not irritating his trachea as much. But what they kind of found out in this episode is that the where he was kind of replacing it was partially occluding the end of the trach tube in some soft tissue at the back of his trachea. And so it actually ended up complicating it a little bit with him keeping his trachea in the way he liked it. Whenever they were bagging him, they probably were actually struggling to get good end-tidal return because the way he was holding his trach in his neck was actually partially obstructing the trach tube. And so, that's a bit of a complicated situation. They did a good job of bringing him to us. They obviously did the things right of he's sat and low. They tried suctioning it. I think hopefully at least as we kind of sit back and get we get to sit in a chair and read over something that was 40 minutes of challenge for someone else. But this really is the kind of case where we strongly encourage a trait change. Just if you've already tried suctioning and you've tried bagging and you've tried applying oxygen and your patient's vital signs are not normalizing, it's a pretty good indicator to do the trach change. Even if it's not because of a mucus plug, I think in this case, at least what you would have done is you would have taken this trach out of this bad position that this patient was keeping this in, put the replacement trach in, and when you place that, at least they might have had a better chance of getting the trach properly lodged to the place it was supposed to be. So, it's a challenging call, and it's certainly no shade on this crew, but it just to speak to that, just when your patient is not getting better despite everything you're doing with their trach, really strongly considering moving on to that trach change is really important. Any questions about that one? I have a few for you today. So the last one is going to be a bit of a challenging topic. And I know we've had some of these tough discussions in here before. But just to talk through real life, just some situations that our crews are going to be encountering more and more as time goes on here in the world. So this was actually a Florida call. I did ask to borrow or to use this call from our Florida Stars coordinator, but this was for a patient they had down there with that long neuro history again as well of epilepsy, cerebral palsy. And so this is just one of those sad cases of a wake up in the morning and the kid has passed in the night. So the EMS crews were called out for a cardiac arrest and an obvious death. They did end up working the code, and so you can see their vital signs from throughout that encounter, including a very low EtCO2. So this is just from their chart, and you can read the history there a little bit if you want, but I'll jump to the treatment portion, which, just describes a well-run pediatric code as they moved the kid to the floor and noted mucus, cleared the airway, did chest compressions and bagging. They were unable to start a line. but had noted obvious signs of death. And so they did actually end up having the discussion with mom there on scene about whether she wanted resuscitative measures to continue or to stop. And after discussing with mom, they did choose to terminate resuscitative efforts. So this continues like this is not common really in any of our careers. I know it happens a little more frequently now, maybe than it used to in the olden days. But I still think that there needs to be a lot of thought that goes into this. So, thinking through your agency's protocols and, not only just like, the legalities of like, can we do it, but like having maybe guidelines for like, okay, what do we do if this does happen? Because this is hard on crew members. This is hard on the police officers and the law enforcement who are there as well. Or it potentially can be like this is a stressful event, right? And I think it will potentially happen more as we have more and more of these medically complex kids and we have different field outcomes and expectations out there. And so I mostly just wanted to highlight this of, I certainly don't expect this to even be the norm or common, but it is potentially something that could happen. And just to give you all a chance to kind of like reflect on that and think through, how are we going to mitigate that for our crew members and the moral distress of these kinds of calls and think that through ahead of time. So I appreciate my Florida partner being willing to let me share that. And I just kind of wanted to talk that through. I'm sure we will have additional talking points about that again some other time. Whether, it's better to transport and resources at the hospital versus, is the family and law enforcement okay there? And that probably varies a little bit on your jurisdiction and your crew members involved. So just some food for thought on that one. Any questions on that? I know that's a tough topic.
I'll
Nick,
just
this
share.
is Angie. Sorry, go ahead.
You go ahead, Angie. Thanks.
I just wanted to throw in there, even though when the crews got there, they probably knew what the outcome was going to be. I think for the family members to at least see them attempt to resuscitate is very helpful. At least the family knows that there was some attempt made and that the efforts just weren't successful. And I think that helps bring closure to families as well.
No, I completely agree, Angie. I think we had talked about this one time before in one of these meetings, and Doc Laffey's point, just to echo what you're saying, is, we as medical providers often know when we walk in the room, but to the family, it's not real until you tell them it's real. And I agree. I do think there's, peace of mind we can give them of this was not quickly reversible. There wasn't some easy seen on TV cure that could have turned this around. That we evaluated it and we tried it. And I agree. Whether you transport or don't transport, I think that's an incredibly important part of it. Did you have something about that?
I was just going to share too, especially from Angie's perspective of that situation in the home in the field. I think a lot of these families have dealt with this complexities for a very long time, caring for their children, and these conversations have happened. But I think that it doesn't really come to a point for them to make that decision until, like Angie said, you're in the moment. Everyone is doing everything they can, and then they come to that decision. I just want people to understand this isn't the first time they probably thought about redirection or removal of support. But I do think, to Angie's point, having all efforts made makes a big difference. So it's probably not a new concept for them to talk about stopping interventions to sustain life, but it feels different in the moment for them.
Agree with all that. All right, to move on topics. So I've talked through these a couple months now, but it is nearly done. In fact, what you can't see behind this ambulance behind me is that there has been endless boxes and work done to send out to the families their stickers. So that will be done by the time we meet again. Those are probably going out sometime next week. And we will be sending these clings to families to put in their windows so that your crew members, even as a redundancy to know that a STARS patient lives there, and also to help families like, tell other family members and home health nursing and like, hey, yeah, we're part of this. if you call 911, this is how the system works, and so we're really trying to help anchor and adopt this in the homes around the kiddos. So this is courtesy of Kim Aslin from St. Charles County suggested this to us, and Melanie and team have run with it here in the office. So we're pretty excited about that. And then just to quickly cruise through the numbers, because I had a lot of call reviews this month, but we added 25 new kids here since our last meeting. The user logins look good. Thank you very much to all of the dispatch agencies for logging in regularly. We did have our largest number of dispatches last September, so 62 in a month was phenomenal. So thank you all for all of your support in doing that. And continue to see, care plan reviews and education being the majority. So you can see about 13% of STARS logins or plan logins were for an emergency. Just as far as transport calls that we know of and no details about for September, we have details on 36 of them and then 8 non-transport calls. And we saw a huge return and improvement in EMS documentation that they knew they were on a STARS call. So we're appreciative. I know some of that comes from here. Thank you, Mr. Denny. So I know that you guys carrying the information forth from this meeting and sharing it is helpful for that. So I appreciate that very much. And then Director Tertiary was super strong for last month. So and then you can see just as far as the numbers, continue to see a lot of trach management throughout this year. That's been a very strong trend. And then just in general, airway and oxygenation support for the patients. So all of that has been super positive. Did see our numbers come down just a little bit on MD approvals, down to back under 5 days. So hopefully we'll continue to see that trend down just as we can speed up that process to new kid gets their plan written and gets into the system so that your EMS providers can access them, especially because as we often see, it's those first few days at home that can really be the diciest. I believe we saw a record this week. Unfortunately, we might have even just put the kid back in the same exact NICU room they left. I'm not sure. I'll have to double check that. But it does that fast recidivism does happen sometimes. Families that it's challenging for them to completely understand and know everything they need to know when they go home, and sometimes that unsettling and uncertainty can really set in quickly. So just making sure you guys are aware of them being home and discharged is important. This will be in the slide deck as well, but just have our education request. If you need any additional training from us or want to schedule some, and that includes the rest of the MS outreach team as well. And then this meeting moving forward, I saw Melanie just posted the QR code in the chat. We did get a few responses, but we were hoping to get just a few more to try and identify the best time slot for 2026 to host this meeting. So if everybody doesn't mind taking just a few minutes to fill that out, it would be greatly appreciated so that we can get the most of you possible in there. And I will come back with that plan in the November meeting. And then I anticipate we will probably cancel the December meeting. I will give you your holidays back. I think everybody's mind space might be in a slightly different place anyways as we get through mid-December. So we'll plan on November being our last 2025 STARS meeting. I'm always available if you need to message or talk to me about something in the interim. So, all right. I did not mean to, but I took us straight to the wire. So I will happily hang on for a couple minutes here if anybody needs to talk to me or team. But other than that, thank you all for joining us today. I appreciate your time very much.
Hey, Nick.
Yeah.
It's Patty from MedStar. Nicole, you might want
Patty.
to stay on here too. We had a child this morning, a 2-year-old, I believe, a Milani minor